I decided to go into medicine, I think when I was my uncle was a physician, Dr. Sanford Lillestrom, and I think he never said to me, it's a nice job, it's a nice thing to do, but he took me around on a couple of house calls and used to take me down to the boys club where I would swim, and he was the boys club physician, $2 a visit down there. But he was an athlete. He loved to talk to the coaches and the swimming coaches and the basketball coaches down there. So I think he went down there mostly for companionship, people to talk to, guys to talk to on his own level, you know. Yeah. But I think because I saw him, I saw how he lived, and not that he was rich, because he was not, but I think that I just liked the idea and it sounded good to me. And when I started Holy Cross, my aunt and he talked to me and said, well, what do you think about medicine? I said, okay. He said, why don't you take Bachelor of Arts? That's Latin, Greek, math, and art. In other words, 2 years of biology and 2 years of art stuff. So I could do anything, pretty much. I could be a teacher, principal, when I got out of there. So I started off pre-med and I ended up pre-med. That's what happened. I did well in the course, so I hung in there.
So after you graduated from Holy Cross, you went off to medical school?
Yeah. Well, there was a hiatus there. I spent a year at Holy Cross, and then I was drafted into the Navy in 1943, and I was an 18-year-old. I won the service, and I was on board an LST in the Pacific, Asiatic Pacific, for 18 months, 2 years, and then I came back and started my second year. The last 3 years I spent following my service time.
Did you see any battle when you were away at the war?
Okinawa. We were in the invasion of Okinawa. That's what our ship did. It was an invasion ship.
How was that? Was that difficult to go through as an
It was very bad for the people who were going to the beach. That happened, fortunately. It was no fighting on the beach. You know, a few mortar shells and things like that, but no real, like the Marines would get it. They really took it, you know. I mean, that's a different kind of story. As soon as we got our load off the ship, which did very quickly, and we tried anyway, I took it off the beach and got out in the harbor, and then it was just a kamikaze worry. But most of them didn't get in. Once in a while when we get into the harbor, but I'm sure when they came sailing over the harbor and looked down, and they saw a battleship here and a couple of destroyers here, they weren't going to fool around with an LST, which I was on, and so we were fortunate.
Yeah. So where did you attend medical school?
Georgetown, Washington, D.C.
Georgetown. And you graduated, do you remember what year you graduated?
1953.
53. Do you remember approximately what it cost?
Exactly. When I started, it cost about $500 to $600 a year. But here's the thing: when you're in the service, we had that time that GI Bill. So the last 3 years at Holy Cross, I were taken care of by the GI Bill. And my first year at medical school, when I started paying the tuitions, it was $600 a year. When I got out, I think it was just going up to $1,000 the year I graduated.
How do you think that compares to today's cost?
Well, my daughter went to medical school, Boston University, and graduated about 8 or 9 years ago. Then it was $25,000 a year tuition, but she'd been a nurse. She worked a little and saved some money, and I could pay. I had 8 children, so I said I could pay their college tuitions, but beyond that, they'd have to pick it up themselves. And she did. She picked. I think she ended up with a bill of $125,000 on those student loans, and been paying them off since, and she's practicing now.
Yeah. Do you think that affects a young doctor's choice as to what they go into?
Somebody really wants it, no. I mean, not when I see my other children who buy homes that cost $200,000 and $225,000, $250,000, If that doesn't bother them, and those jobs they have, and they have good jobs, but not paying big money like some jobs do. But I think that then certainly somebody who goes to medical school can afford to take out loans and pay them off, as they would a mortgage. Probably pay them off in 10, 12, 15 years.
So did you personally have to take out loans when you were going through medical school?
No, well, my uncle, the doctor I mentioned to you, I used to go on house calls with and go to the boys club with, Dr. Lillestrom, lent me $13,000. And that covered the last 3 years of my medical school, believe it or not. And they did pay for I had a room in a house in the area, which they also paid for. So I owed them, I think they had spent $13,000 on me. And after I'd gotten into practice and made some money, I said to him, I said, Sanford, I owe you $13,000. I'll pay it off. He said, forget it. He said, it was money well spent, and that was the way he left it. So I never well, we're lucky, that's all.
Yeah. Were you very close with them?
They lived next door to us. We were very, very close to him. His wife was my aunt, Catherine Reardon, and they were very close. We lived, as I say, 5 steps away from their house, so...
Yeah. So it seems like you really took a liking to him, and he really took a liking to you.
I did. Well, he was a very nice man. He was a very nice man, and he was the president of the Medical Society for a year. And down through the history, if you look at the history of it, you'll see it.
So after finishing medical school, you decided to go on to residency.
I was a Worcester person. I lived down the lake here, about 2 miles, most of my life till I was 30 years old. And so my home was down there. My folks lived down there. I had been out in Detroit. I took a residency here, an internship here at City Hospital, a rotating internship, which was 3 months pediatrics and 3 months surgery, 3 months medicine, and so forth. And then I took a 2-year pediatric residency out in Detroit, Michigan, and finished there in 1956.
So what led to you choosing pediatrics over all the other specialties that are available?
Well, I think even in medical school, when we went through the rotations, as we did there also, in the last 2 years, I noticed that pediatrics, you bring in kids who are terribly sick, you send them home, they're perfectly well, to live another 50, 60, 100 years, who knows. I think that, when you start doing adult medicine, medicine seems to me to be coned down into 2 areas. Pediatrics, where a lot of the kids get sick, infectious diseases and so forth, and old age medicine. And of the 2, I wanted to be with the younger group, and so that's what I did.
So you did your residencies out in Detroit?
Detroit, Michigan, Children's Hospital, Michigan, yeah.
And then after that, did you come back to
I came back to Worcester. First of all, my father had just died a couple of days before that, and second, I'd been offered a couple of jobs in Michigan, in Detroit, but I don't know, I knew everybody in Worcester. I was a Worcesterite. My mother was living here alone now, and I just wanted to get back here and make sure everything was, hold the family together, number one, and number two, this was the place I lived in, and so I was used to it.
So how long did you practice in the Worcester area for?
I quit full-time practice in 1995, which is 6 or 7 years ago, and I wasn't doing nights and weekends. I mean, working every day and doing some covering. Then I worked for 5 years until a couple of years ago in June, just about 2 years this month, working emergency medicine at Fallon, where I finished up.
Was there anything in particular that you enjoyed working in Worcester?
I think not one thing. I think I enjoyed everything about it. Some things I didn't, but I mean, most of the things I did in pediatrics I liked to do, and whether it's just giving advice in the office or whether it's treating sick children or whatever, I liked it all.
I'm sure you saw a lot of changes in Worcester through your years.
Boy, unbelievable. It's unbelievable.
Maybe share some?
Wow. First of all, today, infectious diseases, most of them are wiped out. I mean, our concerns with measles, because every 500 measles, you got a kid with, or every 1,000 maybe, you got a child with measles and encephalitis. Half of them were affected seriously, so they were never normal again. In any big children's ward, we had one of these kids who were just vegetating there, laying with tubes in them, tube fed and so forth until they died. And I think we were used to that kind of thing. And when you took measles away and removed that, plus just the morbidity of having the measles, 50% of the measles kids used to get something, strep throat, or their immunity system was kind of knocked down after they had it, so they got strep throats, pneumonias, all kinds of things afterwards, including encephalitis. That was a bad news disease. Well, that, measles vaccine, gone, just like that. And mumps, chickenpox, those things weren't so serious, although I had a chickenpox encephalitis die on me once. Very helpless. You couldn't do much about it. Once they got it and got encephalitis, goodbye. That was it. I think it's still pretty bad today if they turn up with that kind of thing. Polio is another one. Wow, polio's couldn't do much for them except supportive care. It's gone. It's gone from the hemisphere. I mean, unbelievable stuff.
Yeah.
And the thing is, immunization is done. Well, number 2 antibiotics, of course. I mean, all we had was penicillin, which came out in the 40s, and sulfa came out in the late 30s, which helped a lot. But I mean, they didn't do a complete job at all. And streptomycin came out in the 40s and 50s. Those are our basic drugs when I started practicing: penicillin, sulfa, and streptomycin. Then, as I was getting out of medical school and starting practice, I think erythromycin and tetracycline, and then finished shortly after that chloromycetin, which was a big help, but not in newborns. And so that's the way it went. And since then, there are so many antibiotics now. I wouldn't want to, cephalosporins, just too many to mention even. I couldn't mention them because I don't know them all.
I agree.
all the different families, well, not too many, but the different families of cephalosporins. You know, I don't know what generation they're on now, but last thing I heard was third, but probably fourth or fifth by this time. You know?
Yeah.
They're all good for certain things, but
Yeah. So probably one of the biggest innovations you've seen 3 years of practicing was the invention of different vaccines.
vaccines is number one. Antibiotics, I looked at your questions and thought carefully about it as I could. I think that immunizations, vaccines were number one. They still are, I think. And number two, antibiotics. Number three, I think then you start talking about lab tests, you know, MRIs, ultrasound, CAT scan, you know, those things. Wow, we didn't have anything like that, and I think that things were much tougher in those days, diagnostically.
I ask you that about technological innovations. If
Boy, unbelievable.
anything in particular stands out as really when it first came out, going, wow, I can actually help this person now, and yesterday I would have...
I can't think of it. They came out so slowly and one at a time, and at first they were just like, there were things that hardly anybody would use, and then finally you get to the point they could be used well, especially with cardiology, with the imaging of the heart and stuff like that. Unbelievable, yeah. And catheterization of the heart and injection of stuff. Those things, things are coming out so fast, it's like the sine curve. You know, suddenly they discover one thing and piggyback a lot of things on top of it, and it's just terrific. And of course, I've been kind of out of action for the last 3 or 4 years in terms of seeing. I do a couple of free clinics now at nighttime, but not to, you know.
Which ones?
Well, the Catholic, at St. Anne's I do one, Jerry Claremont's clinic, Dr. Jerry Claremont clinic down in Shrewsbury. And I also do one, just a couple of hours, you know, at St. Bernard's up off Lincoln Street. We have a couple of free clinics up there where they treat people who want to come in there. They're not week after week clinics. I mean, you see somebody, you expect them to get into some kind of a healthcare system, be it Green Island, be it Mass Medical or something, for their regular care. But you can see them once and get them started, you know. That's kind of what we do. What I do anyway in pediatrics.
That's good. Do you enjoy staying active still? I'm sure you do.
Very much so, oh yeah. And my wife is very happy to get me out of the house a little bit.
So another thing over the years, I'm sure you've seen a lot of changes in maybe the patient populations that you've treated or the demographics of Worcester.
Well, the big change would be the Hispanic population, the Spanish-speaking people. There were always blacks here, and it may have changed a little bit. Population may have changed some, but the influx of the Spanish-speaking population has been the big demographic change here. As far as Worcester goes, it used to be up around 200,000, now it's 166,000. It kind of stabilized there. So the city itself has not been growing markedly. And but I would say in the whole area, now the outlying towns have thousands of people and probably 250,000 people involved. There may be more, 300,000 in Worcester, plus the bedroom towns, they call them, around the city.
So you mentioned you have quite a few children.
8. I have 8 children, yeah.
8 children.
Right.
Has it been difficult for you as a physician trying to balance lifestyle as a...
Much more difficult for my wife, I'm telling you. She's a saint. But, you know, imagine doing all those diapers and so forth for 8 kids, man. It's unbelievable. I don't even have to think of it. It's mind-boggling. But, so she deserves a lot of credit. But, yes, but I think the way we practiced pediatrics anyway, the way we practiced pediatrics was... you could do it and do it reasonably as well as you could, because most of us had wives who were at home all day with the children. So we didn't have wives who were working too. That's a problem. I don't know the solution to that problem. Some of my kids had the same problem with their children. But I would always get home for dinner. I was always getting home for dinner, spend an hour there. And then eventually when I get into partnership practice, which was only 2 years after I started, we did every other night, and then a few years later, a third gentleman entered, not our practice, but he entered doing nights with us, so we were every third night, so that helped a lot. That gave you more time at home and so forth. Gave you a weekend off, and every other weekend, and every third weekend you worked, and that was very helpful.
Yeah.
We were just coming, and that's what happened. That was happening in medicine all over. When I started in Detroit as a resident, everybody was in partnership practice out there, you know. So I came back to Worcester, nobody was in partnership practice. It was like Maine, you know. And after a year and a half of doing my own thing, I was signed out on Wednesdays to a physician who eventually became my partner. And I talked to him about joining him, and I joined him for 18 months. he had a much bigger practice than I. But then my practice grew, and I think finally after a year or two, then we started working every other night. That was probably in the 1960s. And then in the 1970s, we went to Fallon and brought in more pediatricians, of course.
So could you describe a typical day for us, maybe like during the beginning of your practice? And then...
Well, of course, in the beginning, it's pretty light because you're not busy. I mean, who's got patients? I think the first day I had 4 patients. They were all people who knew me and brought their youngsters to me, people I knew as growing up, So it was very light then, and I'd sit around a lot of times. But I think if I had people in the hospital, I would make my office hours in the afternoon and hospital rounds in the morning. And I think when I joined my partner, Dr. John Duggan, in partnership practice, that's what we did. One of us, well, first of all, both of us went to the hospital, which was not a great idea. We thought it didn't last very long, and both of us then came to work at 1 o'clock in the afternoon. Then we thought it over and said, gee, why don't one of us, we try every other day in the hospital? So we tried that, So that was great. One of us would go to the hospital, and then the next day another one would go, and the other person would be 9 to 5 in the office. So we had an office 9 to 5. Then we decided to really go on the limb and go for, after we'd been in practice 10 years, we knew we knew each other's patients, and they knew us. And so I think that we'd go for a week. Then we'd spend a week. One man would go to the hospital in the morning, 9 to 12, 9 to 1. He would come in the afternoon. The other one would spend the whole day in the office. We'd do a week of that instead. It worked out much better that way. So that's where it all started.
Did you make any house calls?
Yes. We made a lot of house calls way back, but in 1966 we stopped making house calls. And until then, a lot of house calls on Saturdays and Sundays, especially, and at nighttime after office hours. But you got to remember house calls. People think of house calls, how wonderful they were, but they really weren't wonderful. The light was poor. Somebody got abdominal pain. What do? You're out in Grafton or someplace. You feel somebody's belly, and you're not. It's not bad enough to think this guy's got an appendix right now, but what about tomorrow? And I think that if you could have gotten a white count, you could have got a urine, make sure you didn't have urinary infection. I think that. There were poor ways of examining people, I think. And so I think we all knew that. People didn't know that because people were saying, if he doesn't make house calls. So we all decided at one time, the whole group of practicing pediatrics. By the way, there were only 9 or 10 pediatricians in the whole town. That was it. There was one pediatrician in Southbridge, and that was it. Auburn, Shrewsbury, no pediatricians, nobody. We were it for the whole place. So there weren't many of us. And as Bob Haggerty said when he came up from the Children's Hospital, he was an official down there. He said, the general practitioners must be doing most of the pediatrics here because there's no way 90 of you people could be doing all the pediatrics in this area. So we believed them. But I think that then we started doing, what we would do instead would be what I would do, I think most men did it too, because you'd see them in the, you can go to a hospital, emergency room, and the hospitals they said, you people can use these 2 or 3 rooms in the emergency room. So we did. So I would go home and eat, and everybody would be at the kitchen table, and we'd talk things over the best we could with kids yelling at one another. It's pretty noisy. It was tough, but a lot of noise. Anyway, which was a lot of fun. But anyhow, then I would take my phone calls. We had a telephone exchange, which would collect your calls. Any emergencies, they'd call you. But it was just a routine thing, a fever and so forth. Questions, they would call you. And so I would finish about 7:30 eating. Sometimes I didn't get home, although office hours were 5. I was usually half an hour, 3/4 of an hour late getting through my office hours. And I'd get home 6:30 and eat. And 7:30 I was ready. I'd take my phone calls. And out of 10 phone calls, I probably would have to see 3 people. So I would schedule those 3 people at the City Hospital emergency room or at the St. Vincent emergency room, depending on how things were running. And so I could see them in a good light and get any kind of lab stuff I needed and any ancillary things I needed, be it somebody measuring the baby or things like that. And it was much, much, much better for the patients too, but they didn't think so, but it was. Yeah. So that's what we did, and I think that's kind of how we ran it.
So your whole practice decided as a whole, as a group, your whole practice decided as a group not to do any house calls at one point?
Yes, we did. Well, I went to a meeting. The reason was I was kind of, we had a local medical pediatric society of 9 or 10 of us. We used to have meetings twice a year in different restaurants around town. We'd bring up people, specialists in different areas from Boston, and they'd talk to us as a group. And we'd eat with them, and then they'd talk to us about the infectious diseases or endocrinology or something else. So we ended up, I ended up going to a meeting people were asking me, what are we doing about house calls? Everybody was asking the question, because everybody knew there were a poor way of doing things. And so I went to the meeting in Montreal and I started asking everybody from every place, do you do house calls? No, nobody was doing house calls. We were the only ones, I thought. Even Springfield, I got to know the Springfield pediatricians well. And I talked to them and they said, we don't do them anymore. So I came back, I said, nobody is doing them except us. We are the lone holdouts here. And we're doing probably poor work for foolish reasons. Nobody else is doing them, So I said, you decide. So we took a vote and we decided not to do any more house calls. And I think it was a very smart move at the time.
It's interesting to me because you talk to a lot of people from the older generations and, they bring up the quality of medicine going down, and one of the reasons they cite is, physicians won't do house calls anymore.
I think that's totally wrong. It's totally wrong. It's not, well, there are some people, if you go to a bad asthmatic, maybe it's good to go to the house and see what kind of stuff is around the house so you can tell what the pollens are like in the house, Let's see your bed, let's see your box spring, you got 6 animals in the house, get rid of them, I think that, I would disagree with that in pediatrics anyway. Maybe in older people, all I can speak for is kids. You were better off, but a lot of other things changed beside medicine. When I first came out, a lot of people didn't have cars, but then they had to come on buses, So then I ended up, people ended up getting cars gradually. Most people had cars so they could drive to the emergency room, and I personally think, in pediatrics, much better to see people in the emergency room for you and for them, because in the emergency room you could schedule 3 people and see them in maybe an hour, right? And do whatever lab tests you need to, give them advice, send them home. If you see them at home, you can't do any lab tests. You're going to make a decision right there. Maybe send them to the hospital. How are they going to get there? So I think that it was a much better way of doing things than pediatrics.
Yeah.
We all decided. I think it was a very right decision. I still think so today.
Yeah. To switch gears quite a bit. Were you able to take any vacations at all during your initial years and later on?
Oh yeah. Well, believe it or not, when I went into partnership practice, I can't remember what it was like when I was alone. I was only alone 18 months in solo practice. But I wasn't very busy, and I didn't have a lot to do, so I could take a lot of time. I didn't take time away. I'd stayed around Worcester, but I could, call in the exchange and find out if there's anything doing. But I think that once we decided to take 3 weeks. 2 weeks, my partner and I, John Duggan, would both go to the Cape. He would go a couple of weeks in July, I would go a couple of weeks in August. Then we took a 3rd week to go to a CME meeting someplace, usually the Academy meeting, which was always in Chicago, because Piston Plains would take you so long to get to the West Coast that you had to spend a day both ways, really. So we would try to get to the meeting in Chicago, one of us. And then the other one could probably go to the spring meeting, some other place, Atlanta, or if he could get to us, some other meeting. There were a lot of meetings. The New England Pediatric Society was strong in those days, very early society. And that used to have good meetings. So we would often go to those, and we had CME meetings. Well, we had meetings every week at the hospitals in pediatrics. 9 to 10, we would have a pediatric grand rounds of it.
Were you involved at all academically in teaching residents?
A little bit here. Residents, yes, in the offices. Residents used to come out to the office, and we would, the hospital, there was no hospital, you understand? There was no hospital there. The residents had the residents, we had residents in the hospitals, not members of but the medical students would come out also. But we had residents in the city hospital, had 27 interns and a few residents. They had 27 interns to run that 180-bed hospital with 200 beds, I think it was. Maybe it was more, 300. But it was a much different kind of thing. I mean, it totally different, anyway.
Did you enjoy teaching? Did you enjoy that?
Yeah, I enjoyed it very much, yeah. It slowed you down a lot, no question about it. If you were busy, having a busy day was difficult. But you did a lot of teaching, too. We did a lot of it, an awful lot of it. I mean, teaching not classes, but I mean teaching 2 or 3 men at the bedside and going over things with them.
Yeah. Do you have any fond memories in particular that you look back upon and smile?
Smile, that's... Yeah, I mean, I just can't think of one at the moment. I mean, a lot of family things, but I think that as I was saying, I know a lady, very bright lady, too, and we used to use the patch test for TB on the arm here, started giving the tuberculin test. Then they stopped using it. And I told the lady, here's the patch test, it leaves a mark and so forth. And so she called me 3 or 4 days later. She said, there's a mark there's a mark. And she brought in the patch test and showed me the mark was kind of brown on the patch test, where on the Band-Aid itself instead of on the kid's arm. Kid's arm was great, but I think that was a little bit funny.
So the kid was okay?
Oh, the kid was perfect. There was no...
Overreacting a little bit?
Oh, yeah.
How about not so fond memories? Anything come to mind?
Well, I think that youngster who died with chickenpox encephalitis is a very frightening thing. You just couldn't do anything. The kid came in, he went downhill like a freight train. Nothing you could do.
Yeah.
I have a fond memory. It isn't exactly a smiley memory. When I was a resident in Detroit Children's Hospital, I remember, I'll never forget this day as long as I live. 1st of January 1955, the year before I got out of there, 6 months before I got out of the hospital and finished my residency. I was in the emergency room. There were 30 residents out there. Every night, one of us had to take the all-night. And I had the all-night this night. It was the 1st of January. And I was up. It was very busy that night. We saw some very, very sick kids. And I finally sat down about 5 o'clock in the morning and said, that's got to be it. Suddenly, this black girl came in. She was about 4 years old. And she was sitting down there. She had 104 temp. The nurse told me she's got 104 temp. And I looked at her. She looked kind of sick. And I examined her, looked in her throat, it was beefy red. I thought, Jesus, it's got to be strep. And so I took a culture. I said, sit her there for a minute. And I said, why don't you give her an injection of penicillin before you send her home? And we put her on penicillin by mouth. So she started going, crouping a little bit. I said, hold it a minute. I said, hang on to her for a minute. I said, instead of giving her strep, give her dicristicin, which was penicillin and streptomycin, thinking of H. influenza, right? Because that was one of the drugs that affected H. influenza. We knew that was what caused bad croup. Suddenly she started getting worse and worse, sitting in the chair within 2 or 3 minutes. And I said, let's admit her. So I was writing up the last patient. Suddenly, the mother screams, ah! Kid fell to the floor, grabbed her throat, gurgling, choking. By the time I got over there, she was thrashing. I couldn't do much with her. Finally, she just quieted down and stopped, unconscious. Whew. There she was laying there. And so I said to the nurse, give me a Bart Parker knife blade, because that's what they told us to do. So I tipped her head back, I cut her hair, put a tracheostomy tube in, and then I had to give her not mouth-to-mouth. We didn't know about it in those days, so I just pressed her chest in and out and gave her respirations, artificial respirations for 3 or 4 minutes. And finally she started breathing on her own. She was still unconscious, and by that time anesthesia had come down. The anesthesia people with oxygen and bag and mask and so forth, they hooked up to the tracheostomy tube. I went upstairs on the elevator with her. We had an ENT division in a place where they did all the tracheostomies and stuff. The ones they could do, the ENT residents can do anyway. The ENT resident came in, so then I went back downstairs to the emergency room, finished my hour or two. It was very quiet after that, thank goodness. But anyway, I was concerned about it. She'd been unconscious, and I said, oh boy, I'm afraid what's going to happen to the girl, brain damage. Then somebody came down and said, you see a friend up there on the ENT ward? She's up now, jumping around and so forth. I said, thank God for that. Anyway, when she would come into the outpatient, we had a big outpatient there, $145,000 a year, which was across the street. Every time that lady and the youngster would come in, they would say, here's your private patient. They'd send it to me. So it was very enjoyable to see that patient who was surviving normal and so forth. And eventually the ENT people took the trach out and closed her neck over. Did a good job. But it was just, that was a frightening but rewarding experience.
Must feel good. The girl would have
right.
died.
Oh, yeah, she would have died. She would have died because 2 or 3 weeks before, the same thing had happened, and a youngster died on the way up on the elevator. The same kind of situation.
Wow.
So.
Did you ever solve what was wrong with her?
Huh?
Why did her
I think it was croup, bad croup, H. influenza probably. I couldn't remember what the culture showed on. I would have said H. influenza anyway, just from the sound of it.
Yeah.
It sounded more like croup than epiglottitis, which they didn't make. The croup made that noise, you know.
Yeah.
Epiglottitis weren't exactly the same. They were a little bit different.
Yeah.
We had to know much about the clinical stuff because we didn't have all the lab stuff and so forth. It was just seat of your pants stuff, a lot of it, you know.
A lot of uncertainty in a way, a lot of intuition.
Yeah, it had to be. That was the way it was.
Yeah. So I'm sure you've seen a lot of changes as far as medicine in general goes, such as the advent of Medicaid, Medicare.
Right. Why don't you go back to a step to what we did with those patients before. Now, remember, when this hospital wasn't here, City Hospital, St. Vincent's Hospital, there were 400 or 500 bed hospitals, had outpatient departments. And they had a pediatric area for the outpatient. We had pediatric outpatient every day, and we had 2 or 3 residents in pediatrics. And so people who couldn't pay for stuff would come to the emergency room and get looked at there and get taken care of, and also well baby visits were done there and so forth. So those people were taken care of before by the hospitals and by the outpatients. And the outpatients, you had residents, and every outpatient was covered by a man. In other words, I was like 2 months on City Hospital outpatient of the 12 months. I not only did my own work, I had to make rounds on the service patients upstairs, which are about 40% of the patients, by the way. And so they were taken care of in the hospital where everybody else got the same kind of treatment. And then I would go down and go through if they had any questions, they'd ask me questions about kids that went through and so forth. And so we try to teach outpatient also. And I think the good part about that is that people did not make appointments. You know, people forget this. They did not make appointments. So if they had a hard time getting in, so they get in at 11 o'clock or 10:15. Nobody cared. They just lined up in the outpatient, gave them a number, and if they were very sick, the nurse would say, uh-oh, put them in the front of the line. But I think that usually they were seen in the order they came in. And if they came in late, they were seen anyway. You know, that's where we went. In an office, many of those patients couldn't get in. If you booked 2 or 3 of them together at the same time, they'd suddenly be sitting there in the office, nothing to do. They wouldn't show. A lot of no-shows. And I think for that, the outpatient hospital seemed almost better to take care of them then. But of course, having one doctor was better too. But there were some factors involved in it.
And even though the hospitals and the practitioners... So
that's where Medicaid came. They were already being seen in the emergency rooms and in the outpatients of the hospitals' departments. And they were well seen in PCA Hospital anyway, and St. V's, because I was on service in both places and in the outpatient in both places. All of those pediatricians spent a month or 2 there.
So this was all prior to Medicare and Medicaid?
Prior to it.
And the hospitals were still able to operate?
Well, the thing is this. When I started practice, putting a patient in the hospital cost the insurance company about $15 a day. Right? Now, UMass probably costs $1,500 a day. Well, $1,500 a day. You're talking about a different ballgame, right? Who cares? If somebody had to stay an extra day, they stayed an extra day. It didn't make any difference, you know. But today, if you stay an extra day, it's $1,500, and with the HMO premiums being $4,000 or $5,000, somebody spends 3 days in the hospital. Suddenly, there's one person that better not get in the hospital because you've spent that money already. So, I mean, you've got to keep the numbers. You've got to be much more careful about who you admit, and you can be today with better antibiotics and better care at the outpatients. But I think you can see the problem. That's the problem, I think.
Yeah.
And I'm not blaming the hospitals because you've got to have all these machines that cost millions. They have to amortize these over years and 10 years, and by 5 years go by, and you've got to get a new machine because you got the new age stuff. You know what I mean? I think that's what's happened to the cost of medicine. I think that's what it is, where the money was spent. Yeah. Because it cost them $5 a day. We made rounds on them. We charged people in the hospital $5 a day. But then $15 was what they paid the hospital. $1,500 is what they pay the hospital now. I don't know what they pay the doctors, you know.
Probably more than $5.
I'm sure it's more than $5, but being involved with we'll get into that later, I'm sure, being involved with an HMO, for doctors is a totally different story, you know.
Yeah, actually I'm just going to kind of...
We don't know what the HMO pays, whatever the hospital premiums are. We don't know what that is, except a couple of times a year they come in and report it to us.
So how did your ability to care for patients change after Medicare and Medicaid were put in place?
It became probably a little bit better. It became better for the patients because they now had a doctor. It became much more difficult for us because many of the patients who went to the outpatient, not all of them, but a fair number, could not get to appointments on time. And, if you scheduled them together you have 2 or 3 empty appointments. A couple of people wouldn't show up, and you've already refused people for camp exams and stuff like that. People who kept their appointments, and I think that there was a problem. So we try to schedule them, scatter them in between, so we would be able to get as many patients in as we could.
In the case of being a pediatrician, I'm not sure when Mass Health came through. Is that after you stopped practicing, or?
Well, it was the very, very end. So I think it's a good thing as long as it's paid for. I mean, as long as they pay people. The point is that the government down it, Medicaid, well, you know, Medicaid, great idea, but I think that hospital reports $128 million in arrears. They're not paying the money. They're not paying what it costs. I mean, it's nice to make a plan and then but when you don't pay what it costs, the doctors suffer, the nurses suffer, they go on strike. The doctors haven't gone on strike yet, but I think, you know, I think that's what you're worried about happening with all of this squeezing government say, well, you can have this, but then refusing to say there got to be more taxes to pay for this. I think that's what bothers me, and that's what they do. And that's what's happened. You can see the hospitals, some of the best hospitals in the state get in arrears, millions and millions. HMOs get in arrears. Harvard Community Health Plan a couple of years ago. Everybody is yelling how bad they are and how tough it is and how much suddenly they're going to go under because they've got a $128 million debt. Suddenly, everybody who's been yelling how awful recognizes this outfit's taking care of 1 million people. We better do something to support them instead of just knocking them. I think that's kind of happened a little bit, but I think...
and unfortunately, the CEOs there leave with a $4 or $5 million severance.
Well, you know, that's $4 or $5 million. I'm not sure I agree with all of that stuff. But what are you going to do? Take one case like that and damn the whole system?
Yeah.
Most of the CEOs we had didn't leave with $4 or $5 million at Fallon. In fact, they're still going.
Yeah. So my next question, could you talk a little bit about your involvement with Fallon?
Well, I think John Duggan and I have been in partnership practice for 10 years, which was very good, much better way than solo practice. We could buy things for the office and so forth. There were 2 of us paying for them. We could hire more women to work in the office, and because you got to remember the office: rent, heat, light, 3 girls working for you, right? I mean, you got to pay this up front. This is not. So I think you can understand when you're going to do that kind of thing. What equipment? When we moved to Fallon, we moved in with I think there were 10 or 12 other physicians. We were the first pediatricians. And we liked it because we knew we were going to get, instead of waiting for the Blue Cross Blue Shield check at the end of the month and hoping we get it on time, if it doesn't show up over the weekend, you know, that kind of thing. I think that, because, you know, we were not rich, and people think we're rich. They're wrong. We weren't rich. We're still not rich. I think that it's a mistake. Some doctors like to look rich and buy giant houses and so forth, but I think I live according to my means and so forth. I think most of us do. You'd be surprised when most of us live and still live. So, nobody's getting $1 million bonus or leave when we leave the place by any means. But I think HMOs were great for doctors because we kept practicing the same way, but eventually we got in more physicians. And then eventually we got more sites: Auburn, Westboro, Fallon I'm talking now, you know, Leominster. Then we had to hire new pediatricians. So we ended up with, I think we've got 30, 35 pediatricians now. So, but we work together. The place on Plantation Street is where people get seen at night. Everybody comes in and in a rotation and sees people and so forth.
So did it change your lifestyle or your ability to practice medicine at all? Changing from...
I think it changed me for the better because, you know, when you got a bad diarrhea, you look at him today and you say, I don't think I need to admit him, and I won't. I'll just have her call me in the morning, watch his urine, watch his intake and so forth, although we didn't have the great fluids you got today to give kids. We did the best we could with what we had. We ended up saying, I'd like to see this kid again tomorrow. And then you know it's going to cost $5. $5 is a lot of money in those days. Because our first office fee in '56 was $3. $5 for house calls, believe it or not. Those went up to $5 and $10 after a while. But even bringing somebody in who, some middle-class people in the area, and charging them $10, and that's $10 today, $10 tomorrow. You know, I think that when you get into a place where people paid a quarterly fee or monthly fee, you didn't mind bringing him in tomorrow. Bring him in the next day if you want. You know? Any question, you just bring him in tomorrow. You know, if anything comes up between now and then, call us, please. So I think it was a much better way of handling patients in pediatrics. Can't speak for other specialties. In pediatrics, you could bring them back tomorrow. You could bring them back 5 times. It didn't cost them $2 each time. So I think much better situation. Because by that time, visits were coming $25 a piece, $35 a piece. I think that it was tough to bring somebody in. How you did it in private practice, I don't know. Either you didn't see them or you saw them and didn't charge them. And when you don't charge one person, they go out and say, gee, you didn't charge me. They tell everybody. Now, people get mad at you for that kind of stuff. They say, why not me? And I think that we didn't have to do that kind of thing. I think it was a much better way for us in pediatrics to practice medicine. And the clinical also, we had pension fund. They put a little of our, the whole organization put some money into the pension fund, and we had a profit sharing fund if we had any money to share in the profit sharing, and we eventually did, and so forth. Was much better all around.
Yeah. So you practiced with Fallon for a number of years?
30.
30 years.
30 years.
Wow, quite a few number of years.
Well, we were the first 2 pediatricians. We started the pediatric department. When they opened up practice to other people, they brought us in immediately. That was 1969.
And did anything change being in Fallon over 30 years? I'm sure quite a bit did.
Yes, but gradual change. I think that the main idea was people paid up front every month, however they paid the health plan, their money, and then we did everything for them we needed to do for a salary. Okay. Now, if you saw a massive number of patients, then they would say, okay, next year we're going to be a new pediatrician and we'll push your salary up a little bit, That's what's happened since then. I think that's the way it's been going.
And what's your opinion on HMOs today?
Well, my opinion on HMOs is very high today. I mean, the Massachusetts ones, they're all different. That's the problem. I think if you took us, Fallon Community and Harvard Community Health Plan and some of the that I don't know I just don't know I don't mention them because I don't know their names. They're good, I think. And but all the others I don't know. And you got to remember too that speaking of demographics, I thought about that a little bit. You're talking North Dakota. That's a different ballgame. If you're in Fargo, North Dakota, and your patients are 40 miles away, some of them, you need helicopters, you need ambulance drivers. So I think you got to take into consideration where you live and the terrain in HMOs. I think we've done the right things for the terrain we live in. But if we lived in Fargo, North Dakota, sure we wouldn't have run things the same way, by any means. So I think it's got to be done reasonably slowly with not just some blumpty-blump, here it is, do something with it, with a lot of thought and a lot of medical input, which wasn't what happened last time they tried to put through that thing. 500-man committee with more men and women, no doctors. Wasn't that wonderful? Imagine doing a legal study with no lawyers on it. Imagine that. Just imagine. No physicians. No practicing physicians in there. I think if they do it again and try it again, they're going to have to get practicing physicians in from areas and really think out something proper and try to do that and work at maybe pilot programs and then do it. That's the way it should be done. Instead of just trying to soothe voters and get votes for yourself, which is what happens.
What do you think is some of the most pressing issues that have to be dealt with in medicine today?
Well, I think AIDS, of course. AIDS is, I think more people need to get into HMO kind of care. I mean, a lot of doctors would argue that, because this was originally a fee-for-service, solo practitioner area. They were very good men. They didn't overcharge people. They were kind to people. They did a lot for them. But I just don't think people can go on doing that kind of thing, the way life is lived today. And they just need some kind of insurance that covers them. And that's my thought anyway. I'm sure you get a lot of people who don't agree with that. So maybe we need medical care in the country, I think so, but it's got to be done slowly and carefully by a few bureaucrats, by some sensible senators and congressmen, and by a lot of doctors who understand the area they're from and who are willing to go to work and try some kind of a plan and see how it works first and how it's got to be changed before it becomes a permanent plan. And it's got to be paid. As you can see, with the hospitals not getting paid, they start threatening to go under. Suddenly they feed them a few more dollars. You can't operate like that. You just can't. Medicine can't operate like that. And doctors don't have unions, so they don't yet, anyway. But I think that,
So you think a single-payer system might solve some of the issues that we're facing today? Some of the financial
But a single-payer issue that's done properly only, yes, maybe, that's done properly. But you got to remember there are some kinds of things, chronic care systems like that. There are some things, transplants, experimental medicine. HMOs can't pay for experimental medicine. They can't pay for it. It's got to be done. Somebody's going to pay for it. Okay, NIH then, all right? Somebody. NIH funding to specific areas, specific hospitals to do this kind of thing. I think that's the only way it's going to be solved. Not by dumping them on HMOs and saying, now you pay for it. Because people get up and say, I should see them on television all the time. They wouldn't do my thing, so people send in money, and that isn't right either. But I think that somebody's going to pay for this kind of experimental stuff, but it can't be the HMOs. They have enough trouble covering the basic things in medicine.
Now, my favorite question. What sort of advice would you have for a young physician just beginning to get into medicine?
I'd still get into medicine, that's what I would say. But you've got to be dedicated. I think that you've got to be dedicated. When you go home at night, however hard you worked, you always got a good feeling you've done a lot of good today. That's important. You don't go home wondering if you've done anything bad today. I think you tried to do everything right and good for people. So it's a wonderful area to get into. You can't go into it for money only, crazy, because you just cannot. Now, how are you going to solve the problem of 5-year surgical residencies, 5 or 6 year GU residencies, and not pay these men? I don't know. That's got to be worked out somewhere. I don't know how to work it out. That's beyond my abilities. But yes, very much so. But I think we need more people who sit down with patients and talk to them, and I love to do that. But I think that more people are going into specialties where they only see a few patients, but they do a good job on them, but they spend an hour with a patient, and we have to spend 15 minutes with a patient, and if we get behind, okay, we're 45 minutes at the end of the day, we're behind. I think yes, it costs a lot of money. You should be willing to, like paying a mortgage, you should be willing to pay the mortgage, and because I don't know how you're going to turn the medical schools around in terms of what it costs you. I mean, you're lucky you go here. I mean, that's one thing, but people are paying $25,000, $35,000 a year elsewhere. Well, you can go into the Indian reservation service. They used to pay off $20,000, $25,000 a year loan a year. I mean, there are ways that you can get around it if you want to do it, or if you want to try to pay it off yourself, you can do that too. So I think that if you're dedicated, you go into it anyway. You like it. Go into what you like, which I did.
Do you have anything else to share that maybe I've forgotten to ask?
Can I open this and look at it?
Sure. I'm sure.
No, we covered a lot of the things. Telephone use with patients, we used it a lot. We had a telephone calling hour at 7:30 to 8 in the morning, my partner and I, both of us. So patients would call in. Patients loved that. They loved that service. Any kind of question they could call in about breastfeeding, about anything else. It was a simple questions,
Was that difficult?
Huh?
Was that difficult to fit in your schedule during the day? Or?
How can you see patients, see one every 15 or 20 minutes and take phone calls also, I think we had a nurse who put the patients in the rooms, also did some phone triage. If the secretary was on you had somebody taking the money, somebody putting down, you owe me so much, and I think that took time. I think that we really needed basically 3 people in the office. Even one person, you need at least a couple of people. But where were we? Most of my patients were middle-class patients who lived in Worcester, all over Worcester. A scattering of the surrounding towns, but mostly in the city itself. The big city was bigger when I started. How do patients choose them? I don't know. They just word of mouth, I think. Okay, you covered most of the other things I think that I can see here.
Yeah, we covered quite a bit.
I enjoyed being a doctor, and I still am, and I still enjoy it. And I didn't go into it for the money, and I'm glad I didn't because I haven't got the money. But I think I've got money to retire on and so forth from an HMO. I know some people who worked very hard, had big families, and they're really stretched out. One man worked for Fallon for 10 years, and he said, thank God I worked for Fallon for 10 years and I got some kind of pension, plus my Social Security.
Yeah.
So.
Were you involved at all with medical societies in the
Well, you can only do so many things. I hate to have committees and people say, I'll be on a committee and then not show up. That drive me bananas. So I looked at I was only on one committee, and that was, they were back in the old, there were all kinds of problems back in those days before the HMOs. people's doctors would go to the Cape and not leave anybody covering. And so people would be writing into the newspaper. The society was getting kind of a black eye from it. So I got on that committee. Late Dr. Louis Cataldo ran the committee. And that was an important committee, I thought, because we took everybody in the medical society, dermatologists, surgeons, everybody got on the list for seeing patients at night. Now, if they could swap with somebody else or tell somebody, see two instead of me going to do it, we signed everybody, including ourselves, on the list, so that people got seen. But then people started recognizing we got to leave some coverage when we go home. When we leave and go to the Cape, they would leave a physician covering for them to see their patients. I thought that made a lot of sense and did a lot of good in the society at the time. Now, with HMOs, we don't worry about that because you get coverage at night and coverage in the daytime. It's much better. Medicine is much better today than it was then. But we were trying to prop it up and do what we could at the time to improve it.
Great. We can think of any more questions.
Okay. Can't think of any more answers.